Coming to breast cancer. Yes, breast cancer, the most important risk factors are increased age, early menarche, late menopause, family history of breast cancer, obesity, alcohol and smoking, HRT, that is hormone replacement therapy, nulliparity, and maternal age at first birth, live birth. Breastfeeding is a protective factor. The BRCA gene, which is in family history, there are two genes that are very important, that are BRCA1 and BRCA2. BRCA1 gene is present in located over the 17th chromosome and 17q. BRCA2 is present on the 13th chromosome, 13q. In case of a positive history of family history of breast cancer, person can have these two genes tested, and they can take a prophylaxis by either bilateral prophylactic mastectomy with bilateral salpingo-oophorectomy. The most common type of breast cancer is invasive ductal carcinoma. Coming to the diagnosis, triple assessment of breast is usually done. So here, triple assessment stands for: first is clinical examination with history taking, second is radiological. If the patient is less than 40 years, we do ultrasonography. If the patient is more than 40 years, we do mammography. And histopathologically, we confirm with FNAC and true cut biopsy. Now coming to the investigation of choice, true cut biopsy is the investigation of choice. An investigation for staging of breast cancer, it is PET-CT. PET-CT. Coming to TNM staging, according to TNM staging, we stage the breast cancer. So TX is when it cannot be assessed. T0 is no evidence of primary cancer. TIS is in situ cancer. Now coming to T1MI, that is tumor less than 1 millimeter. T1 is further divided into 3 stages. T1A, that is 1 millimeter. More than 1 millimeter to 5, equal to or less than 5 millimeter. T1B stands for more than 5 millimeter to equal to or less than 10 millimeter. T1C stands for more than 10 millimeter to equal to or less than 20 millimeter. T2 is more than 20 millimeter to 50 millimeter. T3 is more than 50 millimeter. T4 is further divided into 4 stages, where 4A stands for involvement of chest wall. Here pectoralis major is not involved. 4B is skin involvement, especially PUD orange is seen. 4C is chest wall plus skin involvement, and 4D is inflammatory breast cancer, which has the worst prognosis. Coming to nodal staging, N0 stands for no lymph nodes. NX is nodes cannot be assessed. N1 stands for mobile axillary lymph nodes. N2A stands for fixed or matted axillary lymph nodes. N2B stands for internal mammary lymph nodes in absence of axillary lymph node. N3A stands for infraclavicular lymph nodes. N3B stands for internal mammary plus axillary lymph nodes. N3C stands for supraclavicular lymph nodes. Coming to metastasis, M0 is no distant metastasis, MX is distant metastasis cannot be assessed, M1 is distant metastasis present. So most commonly distant metastasis occurs to the vertebral column through the Bateson's plexus, most commonly to the lumbar vertebra. Management. So surgical management that we can do is, first is breast conservation surgery depending on patient's need and age. So here we do lumpectomy. Lumpectomy is done up to 1 millimeter, and mastectomy is the second one. So mastectomy can be of four types. First is radical mastectomy, which was designed and which was told by Halsted, where we remove breast, nipple areolar complex, pectoralis major, pectoralis minor, and level 1, 2, 3 axillary lymph node. Second is modified radical mastectomy. Here the incision we do is elliptical Stewart incision. Here we remove breast, nipple areolar complex, pectoralis fascia plus level 1, 2, 3 axillary lymph node and pectoralis minor. Here pectoralis major is not removed. Now there are three variants in modified radical mastectomy. That is, first is Auchincloss, where pectoris minor is retracted. Scanlon and PT, where pectoris minor is cut. Coming to third is simple mastectomy. Simple mastectomy is when we remove breast, nipple areola complex and pectoris fascia. Here axillary lymph node are not removed. And fourth one is skin and nipple sparing mastectomy. Coming to chemotherapy, indications of chemotherapy is positive lymph nodes, locally advanced breast cancer, ERPR negative but HER2/neu positive tumors. So here what we gives is 6 cycles of CAF or CMF. So CMF stands for, C stands for cyclophosphamide, A stands for adriamycin, F stands for 5-fluorouracil, M stands for methotrexate. Cyclophosphamide has an important adverse drug reaction of hemorrhagic cystitis. In this case, then we have to give mesna. Nowadays, we are also giving 4 cycles of AC, that is adriamycin and cyclophosphamide, followed by 4 cycles of paclitaxel. Herceptin and trastuzumab should be given for 1 year in patients who are HER2/neu positive. It is again followed by hormonal therapy. Indication for hormonal therapy is ERPR positive tumors. So menopausal age group, we give tamoxifen, that of 20 mg OD. It is a selective estrogen receptor modulator. And postmenopausal, we give letrozole, anastrozole or exemestone. These are aromatase inhibitors. Radiotherapy is also given if lymph node is positive, and all patients following breast conservation surgery are given radiotherapy.